A 35-year-old man with advanced HIV presents with right lower quadrant, abdominal pain, and intermittent fevers. I am showing you a supine abdominal radiograph and a spot image from a barium study. Describe the findings.
All right, let's take a look. The barium study demonstrates a long, irregular segment of stricturing and mucosal nodularity involving the terminal ileum. Additionally, there are multiple fine, irregular fistulous tracts extending from the diseased terminal ileum into adjacent small bowel loops. The cecum appears severely contracted and deformed.
What is your primary differential diagnosis for an inflammatory condition causing terminal ileitis, severe cecal contraction, and fistulation in an immunocompromised patient?
The two primary considerations are gastrointestinal tuberculosis and severe fistulizing Crohn's disease.
How might the pattern of cecal involvement help distinguish tuberculosis from Crohn's disease on fluoroscopy?
While both can affect the ileocecal region, tuberculosis is notorious for causing intense, diffuse fibrotic contraction and shortening of the cecum with a gaping, incompetent ileocecal valve. Crohn's disease usually causes more asymmetric, discrete ulcerations and skip lesions.
Why does tuberculosis show such a strong predilection for the ileocecal region specifically?
The mycobacteria preferentially infect areas with an extreme abundance of lymphoid tissue, and the terminal ileum and cecum possess the highest concentration of submucosal Peyer's patches in the gastrointestinal tract.
How would you manage this patient as a radiologist?
I would urgently contact the infectious disease team to report the high suspicion for active ileocecal tuberculosis. I would recommend a prompt colonoscopy with targeted mucosal biopsies for acid-fast bacilli staining and culture to secure the diagnosis, while monitoring the patient closely for signs of complete bowel obstruction requiring surgical intervention.